Welcome, good morning to everyone. Can you hear me? Yes. Thank you. At the outset, I should thank Dr. Ashish Karthik, Dr. Baburaj, and the other office bearers of ISA Thrissur and the ISA Kerala State for organizing this mammoth conference. This is not an easy task to accommodate more than 1,000 people. They have done a wonderful job, and I would like to give them a big applause for their wonderful job. And to start with, I hope all of my friends had posting in the blood bank. How many of you had posting in the blood bank? Can you raise the hands during your course? I believe most of the OT people, OT technician course, people have posting in the blood bank. And if not, don't worry, I will try to accommodate everyone. So I have no conflict of interest and no financial support. And the entire lecture I have prepared is based on the recent ISA scientific lectures, surveys among the senior consultants, among the ISA members. And we have taken into account the intraoperative situations and adjunct medication to prevent and or treat bleeding, about the concept of autologous blood transfusion and the blood ordering schedule. I am sure everyone must be aware of blood ordering schedules and about the restrictive transfusion strategies. So all of you must be aware that now the concept is to give blood components instead of giving whole blood. So why the concept has come? Why the concept of blood component therapy instead of whole blood? This is because the patient can be best treated with the specific components they lack. Suppose the patient has got coagulation problem. You can be treated with fresh frozen plasma instead of whole blood. Why you want to waste the packed cells, which can be given to another patient with a low hemoglobin percentage. And it maximizes the benefits from a single donor. And the storage, as you go down the presentation, you will see that the storage of different components are different, so that you can keep, when you separate and keep it, you can store the different components in ideal setup. And it definitely reduces the risk of infection and immunological reactions. But having said that, the whole blood is sometimes available, depending upon the local guidelines. For especially when you give in trauma patients, massive transfusion settings. But the concept is now to give blood components. Okay. So how to separate the different components? You will have the whole blood and you centrifuge it and get the platelet, what is known as the platelet-rich plasma and the packed cells. From the platelet-rich plasma, you again centrifuge at 20 degrees centigrade and separate the platelets. And you get platelet-poor plasma. And again, you freeze it to minus 70 degrees and thaw it and get the cryoprecipitate and factor 8 poor plasma. And from the platelet-poor plasma, you can get fresh frozen plasma. And when you centrifuge the whole blood, you get the packed cells, which can be freeze to minus 80 degrees centigrade to frozen red cells or leukocyte poor red cells. So this is the, for those who has not gone to the blood bank, this is the centrifugation machine. And this is how it looks once you centrifuge. So you can see that on the top you have plasma separating, and in between you can see a small layer which is known as the buffy coat, which is rich in platelets and leukocytes, and below that you have the erythrocytes. And you can separate from this, you can separate the plasma, which comes here in a separated bag, and in the remaining will have the packed cells and a buffy coat. Now what you see here is the red blood cells and a small buffy coat, and here that is the platelets. And now you can see that from that it has separated into a plasma, which is here, and the red blood cells. And when you go into the blood bank, you can see that there is a chart. There is how the different components are separated and the rotational per minute. So this is how it looks. When a single donor, you have separated different components, RBC, you have fresh frozen plasma, you have platelets, and then you have cryoprecipitate. This is what I said, that from a single donor, you can donate to 4 different components. This is the concept why we are giving blood components, so that the benefit is transferred to 4 people at least. So now we come to individual components, packed cells. So you have seen that it is separated by centrifuging the anticoagulated blood, and the RBC will have 10 ml of additive solution and 200 ml of RBC, and it will have some amount of plasma, though it is separated around 30 ml, which is acceptable. And whenever you transfer, you see that it is ABO compatible and RH compatible. And you have the reason to give RBC is to increase the oxygen delivering capacity. So this is how it is stored. You have O positive PRBC, AB positive PRBC, all blood. Okay. And I will come to the storage conditions. So this, I think students should please note this. Start the hematocrit of the packed cells is 70%. That is, when you compare to whole blood, it is 40%. It is 70% with the packed cells. And please understand that it is incompatible with hypotonic solutions, and the shelf life is maximum 42 days. And it has to be stored between 1 and 6 degrees centigrade. And 1 unit will increase the hemoglobin by 1 gram percentage approximately, and the hematocrit by 3. And left out of fridge for more than 30 minutes, it has to be transfused within 4 hours or discarded. And what is the indication for giving packed red cells? It is rarely indicated when hemoglobin percentage is more than 10 gram percentage, and almost always indicated when the hemoglobin percentage is less than 6 gram percentage. So between 6 and 10 gram percentage, it depends on the clinical situation, like when you have a cardiopulmonary risk factors, or there is an ongoing blood loss, or it depends on the clinical judgment of the physician, that is the anesthesiologist. But the usual transfusion trigger in the OT setup is 7 gram percentage. And as I said, more than 10 gram percentage when the patient has got myocardial infarction or pulmonary disease in the liberal strategy. And transfusion should not be directed by single hemoglobin trigger when you have the hemoglobin percentage. When you have a series of hemoglobin which is falling down, then you can consider. Sometimes it comes from the 9 gram to 8.8 or 8.5, then it stabilizes there and gradually picks up. And you have to think of the risk of developing complications of inadequate oxygenation, like the patient is having tachycardia, hyperventilating because of inadequate oxygenation. And unit by basis, always re-evaluate the unit by basis every 60 minutes. And there are some modifications of the packed cells, like you have leukoreduced packed cells or irradiated packed cells. Leukoirradiation is filtering the white blood cells, and it reduces the incidence of febrile hemolytic reactions. The irradiation prevents transfusion-associated graft versus host reaction, and it is given in immunocompromised patients. Now coming to fresh frozen plasma, it is in the second slide or third slide I have seen it. It is obtained by centrifugation and apheresis, and it contains the coagulation factors, and in addition to that it has antithrombin 3, protein C and S. And it contains electrolytes, albumin, some albumin and immunoglobulin. And the usual dose is 10 to 15 ml per kilogram body weight, which approximately replaces around 30% of the coagulation factors. And for warfarin reversal, you give it at 5 to 8 ml per kilogram body weight. So it is obtained from the supernatant after centrifuging donation of the whole blood, and it has to be frozen within 8 hours. And can be stored up to 1 year in minus 30 degrees centigrade. Please note that point. And the frozen packets are very brittle, so you always cover it and keep it. And for reuse, for using from the storage, it has to be thawed either using dry oven for 10 minutes or water bath for 20 minutes before use. I will show that. And at 4 degrees centigrade, it is stored for 24 hours. So this is how it is stored. This what I said. It is brittle. It is this bottles. This is very brittle. It is how it is stored, and it is covered so that it can be handled better. So this is how it is covered. So this is the thawing machine. So this is how you thaw it before reusing. So this is where it is. Inside this, you keep the FFP. So what is the indications? In case of excessive microvascular bleeding, when the INR is more than 2, or in thrombocytopenic purpura, urgent reversal of warfarin, when the best choice is prothrombin complex concentrate, when it is not available, you give another substitute. And non-coagulation factor deficiencies, when the specific concentrate is not available. And the complications are transfusion-related acute lung injury, and transfusion-associated circulatory overload, and sometimes anaphylactic reactions. And always remember that frozen plasma is not indicated if prothrombin time and INR and APTTA are normal, and it should not be given to augment plasma volume or albumin concentration. Now, coming to our third product, that is platelet concentrate. It is obtained by centrifuging the whole blood and platelet apheresis technique, and it can be given for thrombocytopenia or functional defects. It is stored in 20 to 22 degrees centigrade for 7 days by gentle agitation. I will show that. And it has to be used in ABO compatible patients, and 1 unit increases approximately 7,000 to 10,000. And the platelet concentrate indications is rarely when the count is more than 1 lakh. It is not given, and usually when the count is less than 50,000, it is almost indicated. And it is also indicated when you have dysfunctional platelets with the normal count. And post-op and post-trauma, you keep it more than 1 lakh to reduce the incidence of microvascular bleeding. And the risk of bacterial contamination is very high. And 5 to 6 units of platelets concentrate is required for adult dose. And you have another preparation known as single donor platelets, which is given in transplant settings, especially in liver transplant. It is equivalent to 6 packs. And you have leukocyte depleted or ultraviolet irradiated products also. Now, any patient developing fever within 6 hours, the platelet sepsis is a very strong possibility, and that should be thought in mind. And it is ineffective when in thrombocytopenia due to increased platelet destruction. When there is increased platelet destruction, whatever you give will be destroyed. So there is no point in giving again. Now coming to our last product, which is known as Cryoprecipitate. It is used by partially thawing FFP at 4 degrees centigrade and removing the supernatant. It comes as a supernatant when you thaw the FFP. The shelf life is 1 year at minus 18 degrees centigrade. And it is best ABO compatible, but not important due to small volume. And it is given for 1 unit per 10 kg. And it has to be used within 6 hours of thawing. And please look into the fibrinogen levels before giving cryoprecipitate. Otherwise, it increases the hyperfibrinogenemia. When the fibrinogen concentration is less than 80 to 100 milligram per deciliter, usually we consider giving cryoprecipitate, especially in a bleeding scenario. And it is rarely indicated when the fibrinogen level is more than 150 milligram per deciliter. And it has to be administered through the standard blood filters. So please note that point also. So it is given as an adjunct in massively transfused patients when the fibrinogen concentration, you cannot measure the fibrinogen concentration in a timely fashion. And it is also given in von Willebrand factor deficiency and factor VIII deficiency when the when you don't have the desmopressin. And definitely in hypofibrinogenemia or dysfibrinogenemia. So when you give blood transfusion, what are the things you have to look into? You have to look into the blood loss, ongoing blood loss, and the perfusion of vital organs as reflected by the clinical situations, and the hemoglobin level, which I have mentioned already, and look into the coagulopathy. You can use point of care coagulation monitors like a thromboelastogram, and the adverse reaction effects of transfusion also has to be looked into. And in transfusion in trauma, the hypotension following trauma must be attributed to blood loss unless proved otherwise. You look into the other rare conditions. Make blood samples at the earliest opportunity in massive trauma situations. And you have to activate massive transfusion settings. And now the protocol is to give 1:1:1 or 2:1:1 like RBC, FFP, and platelets. So the blood, what are the blood transfusion steps? Before you transfuse, find the current type. At least 2 persons should check the typing and cross matching. So you confirm it, confirm the patient, and confirm from the blood bank before transfusing to the patient. And you have to see the history, medical health history of the patient, and see that the consent is obtained. In our hospital, you have to get informed consent before giving the transfusion. And before surgery, we get to separate the consent for anesthesia, blood transfusion, when you anticipated blood loss, and you have to give transfusion. Ensure that the patient have a large bore IV cannula. And ensure that you have the tubings, blood warmer available before transfusion. And as I said, always verify the blood product. And please note the baseline vital signs of the patient. What is the pulse rate, what is the temperature, what is the BP, or what is the saturation of the patient, and note it during transfusion and at the end of transfusion, and record it. And always run the blood very slowly in the first 15 minutes. This is the point everyone should take note of it, and remain with the patient in the 15 minutes. Because the transfusion reactions, if any, can happen within the first 15 minutes. So the first 15 minutes of the transfusion is very crucial. You have to be with the patient. Please continue noting the vital signs of the patient. And what are the potential risks or complications? Patient can have allergic reactions. Patient can have fever. That's why I told you, note the baseline temperature of the patient, and note the temperature of the patient during transfusion and at the transfusions, at the end of transfusions also, and acute immune hemolytic reactions, transfusion of infections also another possibility. I have mentioned, well, it is high with the platelets. That's why you don't transfuse the blood products which is kept outside the room temperature for a long time. And patient can have transfusion-related acute lung injury, and especially when you give massive doses of fresh frozen plasma, and patient can have circulatory overload in massive transfusion, and rarely patient can have air embolism also. So when you are asked the examinations, you have to tell some of these complications, so you should be able to say. So if you suspect any reactions, what should you do? Stop transfusion immediately. That is the first step you have to do. And disconnect the blood tubings from the patient, and notify the doctor and blood bank. Call for help. That's very important. And stay with the patient and continue assessing the status of the patient. And you have to document everything. So to conclude, so pre-op assessment and preparation of the patient is important. Before transfusing, please check the blood group, confirm it. At least 2 persons should confirm it. See that you have all facilities for transfusion. Note the vital signs. Note the health history of the patient. Document everything, and be with the patient in the initial stages. And document the vital signs at the end of transfusion also. And nowadays, we go for the restrictive strategy. I have said it in the beginning that we don't have a liberal transfusion strategy which is universally accepted. And we don't go by the single hemoglobin level. We go by the trend of hemoglobin percentage. And the aim is to increase the oxygen carrying capacity. And always judiciously use the components. Don't unnecessarily transfuse, because there will be another patient who really need these components. And always perioperative monitoring of the tissue transfusion and coagulopathy is very important, that the anesthesiologist will be definitely doing it. And thank you once again for the patient listening. And I hope it will be beneficial for the students. Thank you all.